Bon, d'accord. Hola, ¿qué tal? Muy buenos días en América, buenas tardes en Europa. Y es para mí un gusto y un placer poder presentar a dos grandes cirujanos del mundo, que son el profesor Christophe MATHOULIN y el profesor Philippe LIVERNAUX. Professeur Lesiones et MATHOULIN, merci par accepter l'invitation de l'Association mexicaine des chirurgies de la main. C'est un honneur pour nous d'être avec vous. C'est incroyable pour l'Amérique latine et vous étiez avec nous. Merci, merci, merci d'être par cœur parce que c'est, je pense, la première fois que vous étiez avec un webinaire avec de l'Amérique latine. À pétition du professeur MATHOULIN, vos comencé la presentación. El profesor MATHOULIN nos ha pedido iniciar su plática, entonces vamos a compartir la pantalla.
Ok.
Non, pardon, un moment. Déjà. Vous pouvez commencer, professeur. Merci.
Okay, nice to meet you. Thank you, Ramon, for the invitation. It's a pleasure for me to be with you in this very particular period. So we are going to discuss about the scapholinate ligament tears, and because this last decade, there are very incredible change in understanding the lesion and the treatment. I would like to thank, of course, all EWAS members, because thanks to them, we can share our experience, and particularly with Mark Garcia-Elias, my friend. So we start at the beginning by the period one. It was the pioneers, and the first guys discussing about the scapholinate tears were Dobbins and Lynchide to Mayo Clinic. At this period, we believe, and you see there, we believe that the ligament was an arch of soft tissue between the scaphoid and the lunate. But if you see correctly this area, you see that the color of that is not exactly the same as the other place. And in fact, it's true because it's unvascularized plaques. And it is a big change in the understanding. So at this period, we classified the lesion in dynamic and static lesion, and the diagnosis was made by gap, DZ, and scapholinate angle. And we discussed, unfortunately, this lesion very lately. So the treatment was a direct suture, and you see the damage we created to operate and to make a suture of an unvascularized area. So I performed that when I was young because it was a key standard at this period. And unfortunately, the large open approach, the poor purchase of anchor and vascularized compromised area, we have bad result because we tried to repair an unrepairable area. So rapidly, the surgeon tried to create some ligamentoplasty, and you see that the first ligamentoplasty, very close to the current ligamentoplasty, has been presented to AEOS instructional course lecture in 1975. But unfortunately, at this period, probably the ligamentoplasty was performed too late, and Talistic pointed the fact that it doesn't work very well. So because the surgeons are clever, we tried to find other solution, and Blatt proposed in 1987 the capsulodesis and a lot of different ligamentoplasty until the day of 1995, Giorgio Brunelli proposed us a new ligamentoplasty based on a theoretical that the rotary subluxation of scaphoid can appear only if you have a volar STT ligament tears. So we were really happy at this period because we believe that the thing has been solved. And unfortunately, and you see the last report by Moran, Mayo Clinic by Steve, and you see that it doesn't work, and it was not a good solution. We arrived to the second period. It means a period of specialists. We discovered the arthroscopy pushed by Terry Whipple and William Geisler proposed a classification which is similar to the Gilles Dautel's classification, but the more popularized. And with the HIWAS, we modified this classification, adding the stage A, it means only the volar lesion, the stage B, only the dorsal lesion, and the stage C, the complete lesion. And like that, we can ameliorate the sensibility, the perception of this classification. In 2006, there is a very important publication by Marc Garcia-Elias, and asking 5 different questions. He proposed not a classification, but a separation in the 6 groups. And he proposed different technique according to the different groups, from capsulodesis to the denervation until the arthritis. During this period, Rosenwasser in New York proposed the Russell procedure. Melvin had a good idea, but it's very difficult to put the screw in the right place. I succeeded only once, and we published with my friend Michel Levadou and Jean-Michel Cognier paper, and we recommend not to use this technique, which is very complicated to perform. Philippe Cohenot proposed the bone ligament bone procedure, which is a very good idea, but unfortunately, because probably the large approach and the different lesion you can create to the extrinsic ligaments surrounding the system, it doesn't work very well. And you see in 2015, the last paper published by the Mayo Clinic teams, and they have abandoned this technique too. At this period, I published also the dorsal CRB ligamentoplasty, which is not so bad result, but the problem is always the same. With this technique, we obtain a stabilization or not, but if we obtain a good stabilization, the price is a decreasing of flexion of wrist, but it's not acceptable. The free ligament tenodesis was not a modification, but another idea from Brunelli's technique, similar, but mixing my technique and the Brunelli's technique. But you see the approach you need to perform this technique and the complication of the procedure, and it's very complicated. And it is the picture, the PowerPoint from Marc Garcia-Elias we share with me, and you see until with him the result is not very good, and with not good mobility in extension and inflation. So Marc Garcia-Elias said, if my baby, it means the free LT technique, was so great, there wouldn't be so many modifications published. And it's why he recommends not to use this technique when the subluxation cannot be easily reduced, when the lunate is unstable, when the cartilage is not normal, when the patient is extra. So there are a lot of other open techniques by Mark Ross, Corella, Diego Fernandez, who added ligamentoplasty to the Russell procedure, and Andrew Chin in Singapore proposed the antipronation spiral tenodesis, which is probably the most clever technique, but very complicated to perform. And with Marc Garcia-Elias, we can ask this question: where are we going? Is it reasonable to believe that a tendon will ever become a normal ligament? Probably not. Will it ever contain mechanoreceptors? We don't know because the nature is so strong, but probably not too. Will it be able to resist the amount of tension and torques involved in these joints? And the answer, of course, is not. So if you don't know where you're going, you'll probably end up somewhere else. It is a very interesting sentence. So we arrive to the third period, the anatomist, and you'll have, all of you, to create the period 4. It is a current period. So what we know, what we discovered, we know that the STT volar ligaments are very strong. And when we have arthritis in scapholinate lesion. It means a slack 4, slack 3. When you have to remove the scaphoid, the real difficulty is to cut this ligament, which are still attached. And it's why I open volarly to cut this ligament before. So the Brunelli's theory is false. We understood the importance of the tendon, and particularly the flexor carpi radialis, but not only. We understood, in fact, and this is logical if we think clearly, there is 2 bones and there is 2 ligaments, the dorsal scapholinate ligament, the volar scapholinate ligament, and something between. And if you enter in elderly people, you can see a very perfect stabilized joint with no proximal part of interosseous scapholinate ligament, because it's nothing, is unvascularized, and it could be degenerative. We understood the importance of the proprioception, and Mataliotakis at first, but then after Elizabeth Aggart and Marc Garcia-Elias discovered the importance of the proprioception, and particularly the anterosseous anterior nerve and the posterior anterosseous nerve. So please, if you have to operate young people, don't cut it, because we learn to do that, and it's a very bad idea. In 2004, there is a paper, very important, published by Gamal Zaidi, and he obtained the horizontalization of scaphoid on laboratory only when he cut the extrinsic ligament. So it is completely new for us. And we, when I perform the arthroscopy, sometimes I have, a small instability, and the ligament is completely normal. You see here the normal aspect. And when you follow the dorsal part of the scapholinate ligament, you see here there is a rupture of something. And it's very interesting. And you see, I can go until the midcarpal joint. It is the same, a small 2B instability, very small, it's not important. The ligament is intact. It is a normal aspect. Here you see the detachment between the dorsal capsule, extrinsic ligament, and the dorsal scapholinate ligament. And it's why we perform anatomical work in Strasbourg, and we obtain a systematic worsening of scapholinate diastasis after the simple detachment of what we call, with Marc Garcia-Elias' help, the DCSS. It means the dorsal capsulo-scapholinate septum. It means the bridge between the capsule, the extrinsic ligament, and the dorsal scapholinate ligament. So we published different papers about the different lesions, and I initiated anatomical work, and in fact the DCSS structure was identified in all cases, consisting in 3 arches, 2 transverse and 1 in line, forming a confluence into the third, which was larger than the previous mentioned. And you see here, in all cases, we have the dorsal capsule, the dorsal scapholinate ligament, and the bridge. And in fact, if we think about clearly, it's very logical. And this structure, the DCSS, is a bridge, and probably its tears could be considered as the first stage of the scapholinate instability. So, in summary, we understood that we have 2 bones, the scaphoid and the lunate. These bones are attached by 2 ligaments, a dorsal scapholinate ligament and a volar scapholinate ligament. And they are surrounded by extrinsic ligament, particularly dorsally, but also volarly. And dorsally and volarly, the extrinsic ligament are attached by a bridge. We call that the dorsal capsuloscapholinate septum for the dorsal part. And the dorsal is the most important part in the stability of scapholinate ligament, with the dick, the dorsal and carpal ligament, the dorsal capsuloscapholinate septum, and the dorsal scapholinate ligament. So there is a difference between Marc and myself, because Marc believes that we can repair the ligament until the stage 2, and for me, we can go until the stage 4. And it's probably the view of an arthroscopic surgeon between open surgeon. And Marc, following our works, added a new stage, a new question: is the middle lineament, is the lunate uncovering index normal? It means sometimes there is extrinsic ligaments also, and there is all the medial part of the carpus sliding on the radius, moving to the TFCC area. It's complicated, the technique, of course. So we have a predynamic, is a dorsal ganglion. It is another story, but every time you have a dorsal ganglion, a painful dorsal ganglion, take care. Sometimes it's not really a dorsal ganglion. It could be the first stage of the scapholinate instability. The dynamic, stage 1 to 4, and it is at this stage we have to treat the patient. Of course, we can treat as a static case, but it's a little more complicated, and the results are not so good. For the diagnosis, I use the X-rays, the two rays, comparative X-rays, frontal, lateral, frontal in radial and ulnar deviation, and frontal with clenched wrist. With that, I obtain, comparatively, of course, 95% of the diagnosis with the correct interrogatory, of course, and my thumb and the clinical examination. So you can use the CT arthroscan, but I don't like it because there is a little too much false positive and false negative. The MRI could be helped, and of course the arthroscopy is a very good exam. So you know that I describe this technique, which is the arthroscopic dorsal capsular ligamentous repair. It means we just restore the anatomy arthroscopically with a suture. We know very well this technique, you know, because very often the ligament is detached, averse from the scaphoid, and when we arrive to the dorsal part, there is remnant part attached to the lunate and to the scaphoid. And the idea is to put some suture through the capsule, through the extrinsic ligament, and through the intrinsic scapholinate ligament from the ulnar and distal remnant part. So keep in mind this video. You see the importance of instability. The stage is a stage 3C, and we use PDS3O. You see the second suture. We retrieve the second suture here, and we put outside. And at the end, the knot is made outside. It's very simple, and we pull down the knot, which is going to be placed between the scaphoid and the lunate. And I created a big knot in order to have a mechanical effect, because I'm not confident on the quality of the remnant scapholinate tissue. After that, you have just to perform the second knot subcutaneously by the 3-4 portal, and in order to obtain this suture. You know, it is a cadaver, and we had the surprise to see that the width of the suture is really more large than we expected, in fact. So this small video is to summarize the principle of the technique. So the arm is lie on the table. There is a forearm extended with the wrist within extension by a special device. You can choose what you want. You enter by the 6R portal. You see the two suture. You need, of course, to have a part of ligament attached to the scaphoid for this particular technique too. You enter in the mid-carpal. You retrieve the two suture. You put them outside. You perform the knot outside between the two suture. You pull down, and the knot is going to be placed in front of the ligament. And after that, you are just to restore the anatomy. And because it is a vascularized area, the nature is going to be repaired by itself. You can put some car wires if you are not confident in the quality of your suture, but you see it is a case I demonstrated before, and look at that. Is after the suture, you see just with one dorsal knot, we obtain a very good stabilization of the joint. So we perform different modification. If we have a very large suture, you can pass in two different holes in the dorsal capsule, proximally and distally, in order to constrict the capsule. And if ever you don't have any ligament attached to the scaphoid, You put an anchor arthroscopically, it's not very complicated, and you do the same principle of technique. It works very well too. Paco Piñal described, according to my work, the same technique for the volar lesion, either in isolated case or added to the dorsal suture if you have a very large instability. And PCO's technique described the technique which is considered as probably the best almost arthroscopic, almost open technique, surrounded the extrinsic ligament and which repair the volar part and dorsal part of scaphoidinate ligament and the extrinsic ligament too. So you see my series between 90 to 99 to 98, excuse me. You see I perform more than 2,000 researchoscopies, 600 are scaphoidin tears. There is a significant increase in indication the last 7 years. Majority of men, young, and sport injury, and majority of cases. According to the stage, there is a majority of stage 3B and 3C. It seems logical. But you see, the last series was a majority of stage 3, and now we have almost the same level of stage 4 to stage 3. So it means we became confident in this technique and we push the indication further and further. So according to the follow-up is 3 years, the average follow-up. It works very well on the pain. We have failure in 6 cases and alwast always in a static case. The normal flexion in the flexion extension in an 80% is very incredible, you know. A normal pronation supination in all cases. And we have a significant increasing in the strength also. You see, according to the total functional income preoperative to post op, there is a significant difference and no difference between the post-op and contralateral. So, and the most important for us, since we never had any problem with the sporty level, and all the champion you can see in motorcycle, fencing, wrestling, etc., became world champion or gold medal after the repair, and it's very spectacular for us. We were really happy with that. So of course the outcome was related to the stage, was related to the delay. The complication are the slight flexion stiffness, but you see it's between 40 to 60 degrees. It could be considered as a very incredible good result in open surgery. And we have some SUDEC treated and classically healed. The dash is very good also, and according to the Mayo risk score, we obtain very good result. So this case is a very good case for me to explain you the principle of the technique. If you see the X-ray is normal. Here it came with the CT arthroscan, so I go inside the joint, and I had the surprise to see the dorsal ligament detached but still attached. And you see, excuse me for that. And you see in here that there is a very large instability. We call that stage 4, according the Geisler stage. It means we can pass from the mid-carpal to the radiocarpal. So it's very interesting because look at that. We just with the free SPDU, only dorsal attachment, look at the reduction, automatic reduction of the lunate, and the stability. I won't be satisfied with the stability obtained, but now I don't put any. I didn't put any Kawa, but in this case I decided to. It was a professional tennis player, so I decided to put some Kawas, and you see the quality of reduction. And when I remove the Kawas, it's really interesting. Look at that. Here, the interosseous ligament is not repaired as normal because it's an unvascularized area. I remind you that it was the area we repaired before. And dorsally, look at, it's very close to the normal aspect. It means the nature recreated the bridge between the dorsal capsule and the dorsal scaphoidinate ligament. And when we perform the MRI from the cut from the lunate to the scaphoid, very small slice, you see that the reconstruction of the dorsal ligament, dorsal capsule, and dorsal DCFL and the DCSS. And of course, we obtained a very incredible result, very good result. Now he's retired, but he continued to play tennis a long time. The strength is very good, and the range of motion is absolutely perfect. So where are we now? We know that the proximal part of interosseous ligament is not real, is not useful, is not vascularized. So you see this patient has been operated 9 years ago by open technique, but there is no instability, a small instability, because the quality of my repair was not perfect as before, as now, excuse me. But you see that there is no chondral change, and the interosseous ligament is destroyed. This patient has been repaired by arthroscopic technique. It's impossible to pass, and you see that the interosseous ligament is destroyed too. So we are sure now that the interosseous ligament, it means the proximal part of the scapholinate ligament, is not useless. We have a dorsal and a volar one, it's sufficient. The proprioception is very important. The distal volar ligament, ligamentous lesion STT exists? Of course not. I can promise that it's not true. Are isolated region of DCSS pre-instable lesions. It is a pre-instable lesion, and we have to consider that, in fact, there is not a scapholinate ligament, but a scapholinate ligament complex with extrinsic. And we can propose different algorithms. It's very important to understand in stage 1, you have just to put a splint, a cast, what you want. My wife, by motorcycle injury, my instrumentist, by bicycle injury, had both scapholinate tears with gap. I put a cast, they healed the both. So it works very well. In other case, you can use arthroscopic, dorsal, volar, what you want, but arthroscopic technique is sufficient. And in fact, you see that we push the open ligamentoplasty far away. And for me, the only open ligamentoplasty I accepted now is the PCOS technique. So, in fact, we have to believe in nature, which is, of course, stronger than us, and we have to learn to use it. When you put you put a plate on a bone, it is not the plate which is the bone; it's the bone itself. It's the same for the ligament, and it's why the technique I propose is, of course, it is to be ameliorated, but it's very interesting because we just restore the anatomy. So, in conclusion, we can say that the dorsal system seems essential in scapholinate stability. The scapholinate ligament complex is a new concept, and you have to understand the importance of extrinsic ligaments in scapholinate stability. The early diagnosis is requested. The arthroscopic capsulo-ligamentous repair dorsal and volar is simple, reliable procedure, convenient for the patient with chronic scapholinate tears. If you have a bold scaphoid, encore could be requested, and the place of open ligamentoplasty is reduced. And to finish, I would like to thank you once more time, my friend Ramon, for the invitation. But it's very interesting to understand that we have to create the part 4 of the story. And now, from Australia with Mark Ross, from US with Scott and myself, we believe that probably the scapholinate ligament is the secondary stabilizer. And the question is, the extrinsic ligament seems to be really more important in the stability. So we have to think about all the complex. Thank you very much.
Merci, professeur Christophe. C'est incroyable votre présentation et je suis impressionné parce que je pense que tu parles mieux l'anglais que le français.
I don't believe you, but it's very kind.
Non, merci. Et tu veux répondre quelques questions depuis de Philippe, ou tu préfères répondre déjà?
Oui. Yes.
Christophe, tu veux répondre les questions déjà? Si alguien en la audiencia tiene alguna pregunta para el profesor Mathoulin, en lo que yo les comparto el próximo webinar que vamos a tener, que si pudiera ponerlo, claro, que será el próximo 25 con estos profesores. Es la sesión mensual de la asociación y tendremos el gusto de tener a Jeffrey Yao, a Michael Hausman y el doctor Luis Schecker el próximo 25 a las 7 de la tarde de México. Están todos invitados a esta sesión de nuestra asociación. Y vamos a ver ahora... non. C'est mon man, nous n'avons pas de
questions. Thank you very much. Merci
Christophe.
beaucoup, Ramon. Et puis à bientôt.
Non, c'est notre plaisir. Notre plaisir et merci parce que vous êtes la vacances de l'été et c'est incroyable par nous.
We organized really beautiful course and we are really happy to have you with us. Bye-bye, everybody. I go to the kitchen.
Merci. Bye.
Goodbye.
Je sais. Bye bye. Philippe, bienvenue et merci par votre temps et votre disposition pour partir avec nous. Et déjà, c'est partout. Nous pouvons commencer votre présentation, s'il vous plaît.
Buenos días, Juan Ramón.
Hola, Philippe.
Muchas gracias for your invitation.
Merci à toi pour l'acceptation. Et
I guess you can see my
déjà,
screen right now.
Déjà, je vais votre présentation.
Okay.
Seulement, je ne sais si c'est la première, parce que c'est des minimally invasive approach.
Yes.
Ah, ok.
Yes, it is.
Déjà. Bon. C'est commencer.
Je peux commencer?
Oui, tu peux commencer déjà.
Okay. So, good afternoon, everybody. So, I'm Philippe Levernaux from Strasbourg, France, and I thank Juan Ramon for his kind invitation. So, what I would like to talk about with you today is a new surgical approach for distal radius fractures and malunion. As you may know, for distal radius fractures, most of authors used right now volar approaches with locking plates. But according to Orbey and other authors, they like to use a very extensive approach in order to see very well all the fracture fragments. And what I would like to share with you today is to make you understand that it is possible to do exactly the opposite, even easier than an extensive approach. And what I used to say to my friend Orbey when we are fighting in a meeting, if I have any problem with my small incision, I can make it larger. But Orbey, with his large incision, he can't make it smaller. So there is absolutely no risk to try to make a minimally invasive approach for distal radius fractures and malunion. So I live in Strasbourg. This is my hospital. I've got some conflict of interest. One with Argo Medical in Switzerland. I made a prosthesis for distal radius fracture, which is not the topic today, and also with nuclear technique. Yes?
Philippe, pardon. Votre présentation, nous ne pouvons voir complète à l'écran. C'est le mode de présentation n'est pas activé.
Mais si, pourtant, Okay. Here, you can see can you see my arrow here?
Non, oui. Oui, je vais la présentation, mais nous pouvons voir aussi les suivants slides.
You don't see the slide in the right screen? Is that correct?
Oui.
Okay, so I will try to do it like and here, is it correct here?
Non, c'est la même vision.
It's strange because in my screen it is perfect. So okay.
Peut-être si vous fermez la présentation et le pouvez ouvrir après, je pense que ça peut faire mieux.
Okay, I will try to do it again.
Pardon pour ça.
No problem. Here, can you see?
No.
And here, it's perfect on my screen, so I don't understand why it's not working on yours.
Okay. Bon, si tu veux, nous pouvons voir comme ça, pas de problème.
Okay, we will do it like this. I'm sorry, because it's... No. You know, can you see my arrow here? Tu peux voir ma flèche ici qui bouge? Can you see my arrow here?
Oui.
Yes. So look, I am going to the presentation here.
Yeah.
And when I click on it, for me it's working very well, and for you it's not.
No, je ne sais pas pourquoi.
Okay, so maybe there is a technical problem, but anyway, you can see everything. Okay, so I will go on. I will go on with this, and probably I can make it wider. If I do this, could be better. Is it better like this?
Non, dans ce moment seulement l'écran est blanc.
Est blanc?
Oui, blanc, seulement blanc. Nous ne pouvons voir la photographie.
And here?
Non.
Ici?
Non, seulement c'est blanc. Et je ne sais pas qu'est-ce que... Non, je ne sais pas pourquoi.
Okay, so I will stop sharing the screen, then I will do it again. Oh, maybe this? No.
Voilà.
Can you see here?
Je vois votre écran.
Okay. So,
si tu peux commencer la présentation.
Tu vois l'écran là? Tu vois bien? Can you see the screen right now?
Oui.
Oui?
Oui, je vois l'écran.
Okay. So, anyway, so what I would like to share with you is the minimally invasive approach for distal radius fracture and malunion. So I've got some conflict of interest with the new clip techniques. So because I have this conflict of interest, please don't believe me, I'm a liar. I'm just kidding. So can you see here this screen with a table?
Non, je vais complètement tout l'écran avec
the other slides.
L'accès rapide, les rôles, les articles, les présentations.
Okay.
D'accord.
So, shit.
Ah merde.
Puta madre.
Exacto.
And here?
Déjà, voilà.
It's better?
Déjà. Oui.
Tu peux voir l'écran. Est-ce que tu vois un tableau là avec acronyme, définition?
C'est l'acronyme, la définition.
Ok, très bien. Okay.
Déjà.
So about minimally invasive techniques, there are different acronyms. One is Mipo, minimally invasive percutaneous plate osteosynthesis. So if you want to find it on PubMed, you have to type these keywords. The best one is Mipo, minimally invasive plate osteosynthesis. There are other ones, less invasive stabilization systems, or minimally invasive surgery, or transarticular approach and percutaneous plate osteosynthesis. Whatever, that means that there are a lot of papers published about a Mipo, minimally invasive plate osteosynthesis. Not only in distal radius fractures, trauma surgeons, they use minimally invasive plate osteosynthesis on legs, as you can see here, on ribs. Can you see this paper? Yes? Can you see it?
Non, non si le même, the slide with definition.
With the leg?
Oui, non, tu veux voir les prochains? Non.
Ici, tu vois les jambes. Ici, tu vois les jambes, avec les fractures de jambes.
Oui.
Oui? Ok.
Invasive plate osteosynthesis. Mais je vais... Vous changez déjà?
Oui, normalement, tu devrais voir des fractures de jambes, là, ici.
Non. J'aime pas
Ok.
voir.
Houston, we got a problem. So, I don't understand what's going on. I think we should... And here, can you see the... No?
Non, 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 c'est la même.
C'est la même. Okay.
Oui.
So, I think, I'm sorry, I'm really sorry, Juan Ramon, but I need my slides to make you understand what I want to share with you. So, if we can't see it, I think we should postpone this presentation and try to fix these technical problems, because I don't want to make your friends lose their time. What is your opinion?
Je ne sais pas pourquoi, mais si tu peux faire la forme de la présentation, peut-être nous pouvons voir. Je ne sais pas pourquoi c'est la suivante photo à l'écran.
Voilà. Ah, I see. Je vois le problème. Je vois que toi, tu as
voilà, et je t'envoierai par le téléphone votre écran. Si tu peux voir à le téléphone, qu'est-ce qu'il nous faut?
Ouais, j'ai compris. Mais en fait, moi, sur mon écran, je vois autre chose que ce que tu vois sur le live. Donc, je ne sais pas ce qui se passe, mais il doit y avoir un problème technique. Écoute, je propose, excuse-moi, mais je propose d'annuler cette présentation pour ne pas faire perdre de temps à nos collègues et d'essayer de trouver une autre date. Et je me mettrai avec un autre ordinateur parce que là, ça marche pas. Je suis vraiment désolé, mais qu'est-ce que tu en penses?
Mais seulement les dernières opportunités. Si tu es sorti de la présentation, est sorti de l'estudio et rentré, peut-être si tu peux ouvrir et nous pouvons voir si c'est bien. Sinon, nous pouvons faire une autre date.
Ok, je sors du studio.
Son los problemas del internet y bueno, de verdad, una disculpa, pero estos son los imponderables que tenemos con este tipo de cosas y diría yo, nos tendría que pasar, ya nos ha pasado en otras ocasiones, lástima que ahora ha sido con Philippe. De hecho, incluso ahí alguien me puso en un principio que no se veía bien la presentación de Christophe. Yo la verdad es que sí veía bien, pero no sé. Bienvenue.
Merci.
Voilà, c'est la suivante. Oui, c'est une photo avec un bras avec une fracture très grande.
Oui, mais ça ne marche pas. ça ne marche pas parce que je viens tout de suite, à l'instant, je viens de changer avec une autre et ça ne marche toujours pas.
D'accord.
Je pense que...
Si tu peux, tu peux faire le suivant photo de l'écran, tu peux faire parce que...
Là, tu ne vois que les fractures de jambes, là. Je sais que tu vois une fracture de jambe.
Oui,
voilà. Mais moi, je vais te montrer ce que je vois. Hein.
Et la suivante, si nous pouvons voir la suivante, et c'est bien. Si nous ne pouvons voir, c'est impossible.
Non, mais ça ne marche pas, ça ne marche pas.
Bon.
Voilà, je viens de t'envoyer ce que j'ai sur mon écran.
Oui.
Qui est différent de ce que tu vois sur l'écran. Moi, je vois la différence parce que je peux faire un...
Je ne sais pas pourquoi.
Moi non plus, je comprends pas ce qui se passe. Parce que j'en ai fait énormément des webinars, j'ai jamais eu ce problème.
Oui.
Et avec le même ordinateur, donc je comprends pas pourquoi.
Non, notre problème, c'est les technologies. C'est choqué. Ce sont choses qui passées et c'est compréhensible. Bon, et Philippe, si tu veux, nous pouvons faire une autre
oui,
date.
je crois que on fera un essai.
Parce que je ne comprends pas, parce que c'est pas possible que nous pouvons voir la forme de la présentation de votre conférence. Et pardon partout par cet inconvénient, parce que je suis, que tu es c'est la vacances de l'été, mais tout le monde veut voir votre présentation. Et si tu veux, nous pouvons préparer et faire un essai un autre jour. D'accord?
Oui, d'accord.
Oui, parce que si seulement chez les gens, et déjà, avec ce titre, la part supérieure seulement.
Ok.
Cliquez une autre fois.
Mais j'ai essayé plein de fois, mais ça ne marche pas en fait. Hein.
Non, d'accord. Bon, c'est un problème. Je te crée et nous pouvons faire quelques jours que tu peux compartir avec nous une autre date par faire les conférences. D'accord?
Ok.
Bon.
Désolé, je suis vraiment... I'm sorry guys, I don't know what happened with this problem. I don't know. I'm really sorry. So if you agree, we will set up a new presentation. We will postpone this presentation in a few days if Juan Ramon is okay.
No, el doctor nos está proponiendo y vamos a intentar después hacer un ensayo, y si el doctor nos va a hacer favor de repetirlo en otro webinar. Desafortunadamente no sabemos por qué no se veía en modo de presentación, porque hizo todo con el mouse, abrió, entró, como puso Ale, como puso Enrique Vergara, en fin. Pero bueno, son los imponderables de una transmisión en vivo. De cualquier manera, los esperaremos, volveremos a tener. C'est la première fois, Philippe, avec nous, mais ce n'est pas les dernières.
La dernière, mais bien sûr. C'est pas ça qui va nous arrêter.
D'accord. Bueno, muchísimas gracias a todos. Y Philippe, merci partout. Je te parlerai après. D'accord?
D'accord. Désolé.
Chao.
Au revoir. Chao.
Gracias a todos. Terminamos ahora un poco más temprano, 49 minutos. ¿A poco fue así que tuvimos este problema con Philippe? Pero bueno, tuvimos la oportunidad de escuchar al profesor Mathoulin y vamos a convencer bueno, ya Philippe se comprometió a hacerlo y lo veremos pronto para esto. Los invito el próximo miércoles a la sesión, que va a estar Jeffrey Zhao, el doctor Luis Shecker y el doctor Michael Hassman. Va a estar muy interesante a las 7 horas hora del centro de México, 5 de la tarde en San Francisco para Jeffrey Yao, 8 de la noche para el Dr. Shaker y Michael Hausman en el tiempo del este de Estados Unidos, y el resto del mundo ahí se acomodan con los horarios porque yo me hago bolas con todo eso. Muchísimas gracias. Si les ha gustado, de todas maneras, suscríbanse. Tenemos ya más de 1,200, casi 1,300 inscritos en nuestro canal de YouTube. Y esto, pues, queda como esto como un acervo, y ojalá que nos sigan siguiendo en nuestras transmisiones. Y muchas gracias, un abrazo a todos y nos estamos viendo. Cuídense, quédense en casa, los mexicanos con más cuidado porque nuestro gobierno es una basura que no nos cuida, pero nosotros nos podemos cuidar. Un abrazo a todos, chao.